someone asked, like, can you use peptides instead of going on hormone replacement therapy to get, the benefits and, get through perimenopause, menopause? And he was like, no.
No, I was going to be like, no.
He was like, hormones are required post-menopause if you want to live a long, healthy life. He's like, you can live without them. He's like, I don't know about optimizing, but I was like, I loved how he phrased it. He was like,
I know. Yeah, peptide is not, it ain't estradiol. It ain't, we need the real deal, okay?
Exactly. Like, it exists, use it. Don't suffer.
It's funny because like when we talk about some of the peptides, like GLP-1s, right? Sometimes we talk about it in relation to kind of how you're replacing what maybe the body is not being able to produce as well right now, or has, kind of downregulated. And so, why would you even want to do that instead of just the real thing?
It's a yes and. Why can't it be a yes and? I had Dr. Tina Moore on the show, and we talked about all the yes ands, like optimize the thyroid, optimize the hormones, use the GLP-1s and microdose. I mean, like all the tools.
Why not?
Yeah.
I don't understand why it's a yes, an and or. Yeah. I'm like, why is it? Why is this instead of? I'm like, how about the whole damn thing?
How about feel amazing?
How about we deserve all of it?
Exactly.
I'm so done with the what's left. Okay. I am not in the what's left. Like I'm claiming what's left department anymore. I'm taking firsts.
Yeah. My husband makes fun of me because my husband's just very much like oblivious to a lot of it. And I'd tell the story of like, I got hair extensions last year, which I'm obsessed with. And
you amazing, gorgeous.
GLP-1 and like used it properly. Right. And just like immediately dropped 10 pounds of inflammation. Just felt amazing. And now I'm on progesterone. I just started testosterone. And my husband was like, are you okay? I was like, I am amazing. Thank you. I am so much better than okay because of all of this. So yes, please. Okay, let's dive in. I feel like we should already be recording. We're going to have our Liz's husband, our expert over
We're
there.
recording. We're good.
Okay, we're good. Okay. So, hey, welcome back to the Health Revival Show. We are so excited. We have our dear friend that we can call her now that, Dr. Mariza with us. Dr. Mariza, we met in person. I've been following her for a little while, but we met at a Dallas event that we've talked about now quite a bit. And she is all things perimenopause expertise, which is just my jive. And we are so excited for this conversation. So thank you for joining us. Please tell our listeners who you are and, what you do and what you love, and give a little backstory of how you got into this world.
Well, who I am is a perimenopausal woman. Okay. And a mom, all the things, right? I'm every woman, just trying to get by, hopefully better than get by. We're going to be talking about how to do more than just getting by, but there are definitely those days where you're just like, whew, okay, getting by. I'm very blessed to be an author. Probably one of the greatest gifts in this lifetime is getting to just put everything I know into a book that hopefully helps women get the type of care that they deserve, which is the gold standard of care, so that they feel literate and just ready to have the hard conversations with their doctors about what they deserve and what they need. I've been in women's health for 16 years. I feel like I've been fighting this fight for a long time and advocating for women because it's outrageous how poorly our healthcare is managed. And then, I'm a girl who has deep friendships and loves living life and loves being a mom. And, and every day I wake up and I feel very driven by my purpose to show up for women. I always say I serve everybody by serving women. And I believe that in every single cell of my body, because women are the epicenter of all of it. I always say that we are the spoke of the wheel. Everything just radiates from us. And so if we're okay, then everything else is okay. Family's okay. Life is okay. So that's what I'm so excited to have the conversation. Hopefully there's something you guys walk away from today. Oh, you're like, okay, I can take this to the bank.
Oh, I love that you said that. As you know, I'm postpartum right now. Yeah. And the other day my husband was like, I don't know what's going on with you. If it's like postpartum, PMS. I was like, well, I don't know either, but I'm going to start my progesterone again. And so I'm excited to have this conversation.
Because I'm in postpartum. I just had a baby. I don't understand. It's so crazy to me when your partner comes to you and you after already communicated what's going on and you're like in this massive transition and you're just like, I'm in it. I don't know what to tell you, but suck it up, buttercup. Like, do you got me or not?
You got me, which is very good. And I'm very thankful.
I know he's on right now.
No, it's fine. Totally. Like I will know when I'm in it. And like, I'm like, why? Get it together, Liz. Like, this is not the way I want to be acting. damn it, I'm going to punch someone soon if I
Yeah.
don't like.
Yes, and right? Like it's hard because we have a vision of how we want to be or how everyone wants us to be or how we know we can be. And obviously we can optimize and get the support, but also there's a surrender of like, oh wow, this is the season. Like my brain is massively reorganizing right now without my permission. I get it, but it's happening,
Yes. And, so with perimenopause too,
Yeah.
because, we see women having children. So I'm technically, what do they call us? Gestational when
Oh,
we're
no.
A geriatric.
geriatric.
Yeah,
Yeah.
geriatric after 35.
Yeah. Yeah. But, we know that people are entering perimenopause early 30s. So let's open the conversation here because I think some women might be like, well, I'm not in my 40s, so I'm not there yet. And I think that it's worth the conversation to say, no, this can happen early on. And even if you're still in childbearing years, you still might be having some of these symptoms of the crazy hormonal fluctuations and imbalances that do impact our quality of life. So when
Absolutely. It's called the menstrual cycle.
Yeah.
I mean, but like lots of things, again, you think about, let's just kind of imagine the menstrual cycle and right when in the purpose of it, right? That our bodies prime up for the potential of a baby every month. It's like all hands on deck, everybody. We're doing this. We're getting ready. We're releasing an egg. It's ovulation time, right? And that is really the main event. I remember growing up and thinking it was your period because that's all we would ever focus on. It was the period. And let me tell you, that ain't the main event. That isn't it. Like you can't even have that unless unless you've got a nice ovulatory cycle. It really should be called the ovulatory cycle, not the menstrual cycle. I don't know how I understand how we got it wrong. Men. That's what happened there. Like if you're wondering, like that's who named that. It wasn't us. But I think about when it comes to egg quality and good quality menstrual cycle, regulation, it's really about the mitochondria. It's about energy. It's about life force. I mean, that's ultimately what the menstrual cycle is. It's life force. It is a superpower when it's working well. But if we have stressors coming in or we have metabolic issues that are happening or we have inflammation, what do you think the body's going to do? It's going to put a standstill or it's going to, the menstrual cycle is going to be one of those areas that are going to be profoundly impacted because reproduction is such an energetic process. And so even well before perimenopause, many of us could be dealing with polycystic ovarian syndrome, right? PCOS, or we could be dealing with, irregular cycles or not a robust enough ovulation, due to overtraining. There's a lot of things that could be happening that again, when the body's like, oh, mitochondria wise, we're just not safe here. And it requires so much mitochondria to run this system. I always say a lot of people don't know this, but there's more mitochondria before ovulation in the ovaries than any other place in the body. You want to know where all the mitochondria are? They're in the ovaries. They're trying to make babies happen. Okay. And that's such an energetic process. And so you can imagine how easy in this modern day world, where we're seeing so many issues with menstrual cycles, deregulation and irregularities. And, again, ovulation that just isn't what we're hoping for, that leads to luteal issues or period issues, that it's really at the epicenter of, okay, cellular energy and cellular health. And then as we start to head into perimenopause, whether that's mid 30s or late 30s or early 40s, it really is about how many follicles you have. Do you got eggs? How many eggs are left? And, living in this modern day world, are they robust enough to keep driving that reproductive longevity? And so we can get into all of that, but I know it gets a little bit messy when we start to see menstrual cycle struggles and irregularities that kind of look like perimenopause, but it's some other forces that are driving that, your deregulation.
Yeah. I think one thing, I love Dr. Tina Moore. I listen to her all the time. And one thing that I remember her saying actually on a more recent podcast is like, we cannot discount the stress that your body has accumulated over your years of life. And you don't just like get a new slate every day you wake up. It's if you have spent, in my situation personally, like I spent close to a decade overtraining. I was competing in CrossFit like 2 hours a day, 6 days a week, and not taking enough recovery, probably not eating enough, not intentionally, but like just with how much I was active and managing a gym, coaching classes, like moving, that accumulated over time. So by the time I was, I didn't have a period for 3 years. And so by the time I'm now 35, guess what? My hormones ain't probably ever going to get back to where they were supposed to be at this age in life, and why I'm already on progesterone to help, because my period was going down to like 24 days, 23 days, right? I was having more estrogen dominant like symptoms, even though I have low estrogen too. So like, I think a lot of people also don't realize the accumulation over time and what that does mitochondrially. I don't think mitochondrially is a
No,
word,
but
but
yeah, to the mitochondria. Absolutely.
and how it can affect you and kind of put you into what I consider like a low hormone state, which technically isn't menopause or perimenopause, but like it feels like it, right? And so I would love for you to, are there ways that you decipher? Because I know you do a lot of labs and you do a lot of
Mhm.
testing for your clients too. Are there ways that you decipher that low hormone state versus, is it the AMH? Is it, the follicle number and what's left there? Or what are you seeing kind of deciphering those differences?
Absolutely. Well, I think you're speaking to a big part of it, which is stress, and overtraining, tell again, that's very much letting the body know that it's just not safe. It's not a safe environment right now. Not enough nutrients. The body's depleted. Your cellular level, it's very depleted, and the body's like, okay, well, it's not baby making time. It's so yeah. And ultimately as a result, that communication between the brain and the ovaries begins to disrupt. And then we start to see hormones begin to decline. Absolutely. And same thing with again, polycystic ovarian syndrome, where a lot of it, the crux of it is insulin resistance. It's fundamentally a metabolic issue. Now, are there nuances where it's more just kind of just androgens driving the show? Absolutely. But a lot of the time it's more of a metabolic issue than anything else. And if we can get that insulin resistance under control, then we can bring hormones back online in a very balanced state. But yeah, I think you nailed it right there. Is stress is accumulating, and even and it's not, you're right. No, there's no clean slate every day. And I would wager that everyone's dealing with stress daily, every day, no matter what. And so that is adding up, and that has a profound impact on our body's ability, that communication between the brain and the ovaries, if we're releasing follicles or not, if we're preparing follicles or not. And so what you're experiencing right there ultimately can land in, primary ovarian insufficiency, where the ovaries are kind of like, maybe maybe we're retiring a little earlier. Maybe we're just kind of taking a break, and then how do you start that back up? Often it's with hormones to kind of let the body know and the brain know, like, oh, let's get back to business, everybody. And so, yeah, I mean, it's very nuanced, depends on the case. It depends on the woman. A lot of the women I'm looking at, in perimenopause, not so often earlier. Usually it's in the late 30s, early 40s. Again, relative insulin resistance, relative estrogen dominance, low levels of progesterone, sometimes a little bit of a relative more androgenic state. It depends. Some women are very low testosterone. So it depends. And yes, hormones are a play here, but also lifestyle medicine. Like, what can we do lifestyle wise to help support your body, to tell your cells and your mitochondria that we're okay, and to note that again, this is a system that's going offline as a natural process.
Yeah.
Yeah, and I think one of the things you mentioned there, I mean, at the health of the cell, we could take all the hormones, but not be able to hear the signals, right? Like
Exactly.
I have a couple of clients who've gone on testosterone and they're not necessarily feeling any better with it or feeling, more libido with it. And it's like, well, you've got some cellular work to do, right? In terms of, I mean, blood sugars look okay, but that's one of the things that we're really focusing on right now and trying to get into autophagy and really clean house so that we can resensitize the cells. And I just don't think that a lot of people understand that piece of it, right? That you can waste, just as like you can waste money on supplements, you can waste money on hormones if you're going to a med spa, right? And they're just, how do you feel? This is what you need. Take this. We'll sell you $700 a month. Keep coming back, but you are just cranking doses or eventually quit because you don't feel it. So can we talk a little bit about that in terms of inflammation and cell signaling and why some people can go on hormones and not necessarily feel better because they're not hearing or receiving the hormone to the cell?
Yeah, I mean, I think, when I look at a full panel, I'm looking at inflammatory markers. I want to see the full picture. And I always say anytime as a practitioner, if we're getting into this and you're looking for somebody to work with, your practitioner should be looking at one, your struggles, your symptoms, what is going on with you. We're trying to read the tea leaves here. That's what we're trying to do. So I'm taking in symptoms, history. How are you living life right now? How have you been living life? Then labs, because labs are often ideally validating a lot of what you're going through, or maybe there's something that we don't know about yet. And then your goals. What is it that you want? What is it that you're looking to achieve? What is your what's ultimate health look like for you? How do you want to be living your life? All of those things need to be taken into consideration. And so, yeah, if I have somebody who's really inflamed, throwing testosterone in on it isn't going to fix that problem, or throwing progesterone on it isn't going to fix that problem. Hormones aren't going to regulate your stress response system. Not entirely. I always say hormones aren't going to lift weights for you. They're not going to take you for a walk. They're not going to get you out in sunlight. They're not going to detox your cell. They're not going to do any of those things. They're not going to help regulate your stress response system and tell your cells to not be in stranger danger mode. They're not going to do any of that. They're optimizers. And so if a lot of the, what I call the boxes on the checklist aren't checked, like gut support, like you're having good gut support, having good strategies around stress management, having a good nighttime and morning routine. I mean, really lifestyle really needs to be dialed before we bring these in. So often women are promised these dreams of hormones fixing everything, and they're just not a fix-all. They're an optimizer. So it's always a yes and. And often hormones can have a light bulb moment 100%. Like I can see progesterone just, and I always let them know, like we've got to build in this lifestyle. We have to go and dig a little bit deeper, making sure that these hormones are going to do what they do. And so, although I'm not going to be hesitant per se, like I'm not holding hormones from somebody, but I also want to ensure that they know that this is a whole body approach, and that they shouldn't expect these hormones to just, be the end all be all to them feeling like themselves again, or feeling more energized again. So it's way more than that.
Yeah. I always have to remind people, HRT is not a weight loss drug. It's not a sleeping pill. It's not, it is optimization. And I would love for you to kind of back up, and we've talked about the importance of HRT, but why it's there. I'm sorry, we've talked about why we think it's important in terms of like, you need it, but talking about the why around what the loss of hormones initiates for females. Cause I think that's something that a lot of women don't understand. And I was actually talking to Liz about this earlier, in terms of, I've had so many women that have been messaging me just alone today that are like, well, since perimenopause, now I have joint pain, or I have brain fog, or I have weight gain, or I can't sleep, or whatever it might be. And you talked about in Dallas, one thing that I love is that so many women do not enter perimenopause healthy, and they think the perimenopause is the reason that they're dealing with a lot of symptoms. And yes, it can be kind of a trigger or like a catalyst event, but there were things brewing prior to perimenopause. And so I would love for you to kind of discuss, physiologically what that low hormone, or this beginning of low hormone, starts to kind of initiate in the body.
Yeah, absolutely. I wish that we were coming in, a lot of us, with a clean bill of health. And when we hit perimenopause, that we were kind of set up a little bit to win. I just want to back up and just share, a lot of recognizing that perimenopause existed didn't really happen until, I would say, the last decade, give or take, where we were like, and even then we really thought perimenopause was late perimenopause. And it was basically 5 symptoms: vaginal dryness, low libido, hot flashes, night sweats, maybe sleep issues. That was it. And flooding. I feel like a lot of it was bikini medicine. Like, unless it's boobs and reproductive health, then our hands are tied. You're just getting old, and too bad. Suck it up. And so now we understand that. I mean, think about even, your typical traditional OBGYN or primary doctor still believes that progesterone is only given to protect the uterus. Again, that is bikini medicine at its core. Like, you don't need it if you don't have a uterus. Because it's not doing anything. It's not doing anything else in the body. And so we now know, we're very clear, both estrogen and progesterone, and although estrogen, she is very much the queen bee, that they are whole body hormones. And, and the first hormone that's going to really, so I always I like to break down perimenopause really in 4 phases, although it's technically officially only 2, because again, gosh forbid we recognize the nuance of this journey, and so we first start with kind of early peri, which is usually mid to late 30s, late 30s for many of us, maybe even into the early 40s. Find out when your mama went through menopause and kind of subtract about 8 years, give or take. And that's kind of when you're going to be starting. There's some small nuances depending on how many children you had, when you started your period. Those can maybe buy you some years from what we know with the research right now. So, but usually when your mom went through menopause, it's probably a really good indicator. And then reverse engineer that. So let's say my mom was 52 years old. So I would probably start to notice things in my early 40s. But if I came in to my early 40s with low progesterone already due to living my life the way that I was living it, then I may notice a little bit earlier than that because I'm kind of starting at a lower point, right? And so what I always say is women will notice the daily pay points of everyday life. You know, we're so easy to blame, oh, well, you're a mom, or you're in postpartum, or, oh, you're too stressed, or, oh, you're just dealing with all these things. And yes, I'm not discounting that these things are true, but all of a sudden it feels like you were able to handle those maybe 6 months ago, all of that in a different way. And now it has shifted. It feels a little bit harder. You have less stress tolerance. You're noticing it takes a little bit more intention to get to bed at night. Things just aren't firing the way that they used to. The everyday ways that you operated, now you're having to just try a little bit harder to get those things done. That is early perimenopause. And again, easily written off as symptoms you've had in the past or lifing, or you getting a little bit older. And so that's when to really start to recognize this. The second you begin to say, something doesn't feel right. Like I'm not the way I was. Like, I don't really feel like myself. That's probably early peri. And then early perimenopause. Again, cycles are still normal, quote unquote, in an ideal situation, but maybe they're a little bit shorter. So maybe at a 28-day cycle, now it's a 26-day cycle. Maybe you notice that, those 3 days of PMS is now 5 days of PMS. It starts to blend a little bit more. All of a sudden, it doesn't feel as distinct anymore. That you could just nail it on the head. It starts to there's a gray area in the luteal phase where things start to get a little funky. You'll also notice, again, those symptoms are just a little bit more intense and potentially more relative estrogen dominance. So you'll start to notice maybe migraines, fibrocystic tender breast, lumpy breast, more bloating, maybe more weight distribution on the hips, thighs, and butt. Like those are the types of things you may notice because again, with progesterone dropping, estradiol, she's probably still hanging on as much as she can. So there may be just a relative shift, something to be paying attention to. But again, because your cycle's normal and, supposedly you're fine, but just know that things are shifting there. And that can happen anywhere between, again, late 30s to early 40s, even into mid 40s. Your cycle could be consistent, but you start to notice these other changes. And then as we kind of saunter from kind of early into late perimenopause, and what distinguishes late perimenopause is you are skipping a cycle more than 60 days. And then you're basically within the 4-year window of menopause. So this is where we always thought that women were in peri when we didn't realize that this whole time that they were in perimenopause. Estradiol is very erratic at this point, very inconsistent. Although there was slight variations of estradiol in the earlier part of perimenopause, and now it's becoming very blatant. So again, you'll start to notice maybe even vaginal dryness, low libido, hot flashes, night sweats. Like it's the eye of the storm. Maybe flooding, and then no periods for a while, frozen shoulder, all of a sudden weight gain, lipids are going in unfavorable directions, blood glucose is going in unfavorable directions, increase in inflammation. It really just feels like a tidal wave of things shifting. And that's really because in a lot of ways, due to the erratic binding of estradiol and progesterone to these receptor sites, this is a default inflammatory state. We are seeing a massive increase in inflammation at this point, particularly in the brain, the cardiovascular system, the muscle, joints, maybe even the mouth. The microbiome is shifting. Everything begins to shift as we start to have this erratic binding. I always think about it as like, you're dating this kind of the bad boyfriend or like and he just starts ghosting you, especially with your brain. Estradiol is binding to you one moment, but you've been so reliant on this relationship and all of a sudden you start getting ghosted. And so estradiol is hands down the CEO of our brains, of a woman's brain. It is the master regulator. It is regulating, it's controlling inflammation, it's controlling glucose metabolism, it is controlling neuronal growth. I mean, it's controlling everything inside of the brain. And so as that connection or disconnection begins to happen, we start to see an increase in inflammation and a lot of brain related symptoms. And I would say that 80% of perimenopausal symptoms, at least in the inception of perimenopause, those first like 4 to 5 years, are very brain derived. I mean, even hot flashes and night sweats are brain derived. And so something to be paying attention to that we tend to not have a lot of extra grace for when it comes to women is that their brains are massively shifting and changing due to this erratic binding of estradiol to receptor sites in the brain and even progesterone to receptor sites in the brain.
And so just in layman's terms for people, this is where you don't remember words, you have short-term memory loss, right?
Mood swings, irritability, low stress tolerance, struggles going to sleep at night, waking up in the middle of the night. I mean, all of this is brain derived.
Can you also talk a little bit about just cardiovascular integrity? And I've had a handful of women just this month with crazy migraines, as well as ringing in the ear or fluid retention behind the ear. And just from the research that I was doing, I know Becca sees this a lot with some of her clients too. A lot of that has to do with perimenopause, and people aren't making these connections.
It has everything to do with estradiol. Gosh darn it, estradiol, just hold on for dear life. Please, or bring her on, right? Bring her on board. The migraines are estradiol. And I just shake my head because I have migraines. I still get migraines and they're hormone related. And I'm really playing with estrogen. I'm playing with a lot of things to kind of get these migraines under control. And 78% of migraine sufferers are women. And so there's a part of me that's like, man, how is it that we haven't gotten this right? How are we missing the boat on how to treat this? When it's the third most disabling neurological condition that you can have. It is that disruptive and that painful, and that, you think about migraines, they're a syndrome. It's not just the pain. Like for me, I can get in front of the pain and it's medically managed at this point, as a mom and all the things, like I need to be a functional human being. But even with drugs, even with pain medications, particular to migraines, it's a syndrome. So drugs or no drugs, my brain's fried for the day. My ability to focus and think is gone. So yes, the pain I got under control, but what about all the other symptoms? It literally feels like someone scrambles my brain for the entire day. And so, so as a migraine sufferer, a big part of that is that erratic decline in estradiol, that kind of fall off the cliff. From what we know, there's still so much unknown in it. But you can imagine in perimenopause, that becomes so unpredictable. And when we think about estradiol peaks, they're often right before ovulation and obviously halfway through the luteal phase. Kind of, if it's not consistent and we fall off that cliff on the other side, is where we'll see that migraine pop up. And again, we still don't know enough. There's so many, I cannot tell you how many hormone migraine protocols I have tried. I have tried on people, and some of them work on some women, some of them don't. It can be really difficult to kind of figure out the right strategy for each woman, each person, but it really upticks in perimenopause due to the erratic nature of estrogen. Yeah. And same with the ringing in the ears and the fluid in the ears, same with the bleeding gums in the mouth. This is a lack of estradiol that is driving inflammation.
Tinnitus too.
Yeah. And I mean, again, we don't exactly know the direct connection of how that's working, but yes, even tinnitus. Yeah.
I mean,
obviously we understand things like frozen shoulder and joint pain. We know that, estradiol is, again, it's a powerful anti-inflammatory, and we start to lose that. And we start to see this buildup of inflammation. And for every woman, inflammation can show up in a lot of different places. I mean, I think about insulin resistance as pure inflammation, and reproductive, where is insulin resistance going to strike? Is it going to be reproductive health, PCOS? Is it going to be insulin of the brain, right? Where you brain fog and a lack of word recall. And we start to see a change in glucose metabolism. If 66% of dementia patients are women, we have to look at, well, what's happening with glucose metabolism in the brain after perimenopause? That is a defining moment where estradiol was regulating insulin sensitivity in the brain. And as she declines, we see this decline in glucose metabolism in the brain. And so how are we addressing metabolic flexibility in the brain as we're going through perimenopause and menopause? I mean, yes, obviously bringing on estradiol is a full body yes, but we also need to address the metabolic flexibility aspect of it as well. It's a yes and for women. Like if women can't find another way to use substrates for brain energy, we find ourselves in a situation where we see an increase in brain inflammation.
Yeah, gosh. And I think one of the hardest things, and would love your thoughts on how you've approached this, is the erraticness of estrogen during perimenopause, right? And so you have people that go through months where they feel a lot more stable, they feel pretty good. And then out of nowhere, you get breast tenderness and massive bloating, maybe an irregular period, horrible bleeding, whatever it might be, constipation, digestive related things. I know you discussed putting estrogen in before you lose the cycle. Would love your, like, how you go about doing that and when you decide that and kind of what's evaluated.
Yeah,
When,
absolutely. I will say that we are still figuring it all out, because in terms of treatment protocol, hormone treatment protocol for perimenopause, again, anecdotally, a lot of us are out there trying to figure it out, but there's no like standard of care. Whereas with menopause, we kind of understand. I mean, there's a lot of arguments about how to do it and, physiological dosing versus just enough to get by, a very conservative symptom management approach, right? It depends on who you're talking to and what kind of doctor you're working with. I mean, I think a lot of doctors universally are now on the same page that HRT for women, particularly in menopause or late peri, even the whole defining menopause as having to wait until you haven't had a period for 12 months is just mind blowing to me. It's just lazy medicine. Like we're just going to wait until you are at ground zero for months and months before we do anything proactive to support you. That just doesn't.
research doesn't even show that it's beneficial. The longer you wait, the worse the research is in terms of the benefit for it. And the more dangerous technically it becomes the longer you wait.
Yeah. And that's more so because, again, metabolic issues and inflammation and cardiovascular risk factors. I know you guys asked me about, what happens when we start to lose estradiol when it comes to our cardiovascular health. One of the things I mentioned was unfavorable lipids, right? All of it starts to rise out of range, but more so our vascular walls become more rigid. Nitric oxide starts to drop. There's a multifaceted approach in terms how we become more at risk for cardiovascular health throughout, not menopause, throughout perimenopause. I cannot tell you how much research is out there when women start everything's normal. There's no, again, looking at calcification in the carotid arteries, everything's good to go. We get to menopause, right? Not post-menopause. We're talking about we just crossed the quote unquote threshold and we start to see this cardiovascular risk. So I always tell people, when we start to see cardiovascular risk factors and a shift in, cardiovascular health moving in the direction of inflammation and more cardiovascular risk, it's happening in midlife. It's not happening in way post-menopause. It's continuing to happen there, but the shift started to happen in peri when we started to see that erratic loss of estradiol. And so I just want you to know that if there was a window of opportunity and vulnerability, it is perimenopause. That is when we need to be looking at all of these numbers, not just your hormone numbers, but your cardiovascular numbers, and deeper look into your ApoB, your lipoprotein little a, you're looking at fibrinogen, homocysteine, your SED rate, all of this. I want to look at all the cardiovascular markers and see in a timeline, do we start to see those shift over that course of 10 years? And when we begin to see that shift, we need to start implementing changes immediately. But it's because we start to see more metabolic issues, more cardiovascular inflammation as we get older, that then estradiol becomes more concerning. But if a woman is in her 60s, even in her 70s, and everything looks great. Yes, an initiation of estradiol is probably you can still do it. Again, everyone needs to be looked at individually. But yes, the sooner it's a preventative. All these hormones are more of a preventative than anything else. So the sooner that you can get on them, the better. And two things that should be dictating care is symptoms and labs. Now, labs, people will tell you it's a fool's errand. But a lot of labs can tell us a lot. I'm talking, they'll say hormone labs. Like it's a shot in the dark. You just don't know what you're looking at one single moment in time. I always say, look at everything. Like, why can't we dictate hormone therapy based on many labs and decide, but also symptoms too? And so it's, again, when it comes to perimenopause, you'll get an argument of estradiol shouldn't be started until late perimenopause when you're starting to skip periods. But then there's a lot of arguments that say, okay, if symptoms are significant and disruptive, it is a major consideration. And then the consideration becomes, well, are we supplementing with estradiol, or when are we doing what I call the full takeover? So we bring on all the estrogen, and basically we tell the body, hey, we're going to handle this from the outside in. We're going to bring on, HRT, and we're just going to take over. And so there's a fine moment. Like right now, I'm in that moment where I'm like, am I just supplementing, or am I doing the full takeover? What am I doing here? And so I'm just kind of in this kind of moment where we're figuring that out. And so I would say in perimenopause, because the one thing that I can guarantee is that your body is constantly changing, and some months are really great, and then you have this really not so great month, right? Really, it's a lot of playing with it. It's a lot of experimentation and getting it right. For you, Becca, like figuring out, is testosterone, is it now? Do I want to wait a little bit longer? Do I want to optimize progesterone first? Do I want to rhythmically cycle progesterone? And so it's really, the beautiful thing about it is that you do get to play. You do get to figure it out and taper it and experiment for yourself. I mean, working with someone who's very hormone literate and who's watching your symptoms, who's tracking alongside of you, who's looking at labs at the same time, all of that is a consideration. The thing that gets a little bit tricky there is really the cost too. Is like, are you working with someone who's really going to be by your side, who's open-minded, who is willing to look at this, look at your symptoms, see how you're doing, look at your labs, and being open to what's going on with your experience versus just they're following the protocol? And so again, that gets a bit more tricky, because as I'm having this conversation, as I'm saying this to everyone listening, you're like, where the hell do I find that person? Where is she? And I get that it is a little bit tricky. So menopause is a lot easier to dial HRT, even physiologically, than it is in peri. But in peri, it is possible. And you'll find that it's a little bit easier to dial the further in we get into perimenopause, to be honest. And so I do tell women that, in that early to middle part of it's going to be relying on a lot of lifestyle medicine, a lot of habits that you're implementing, a lot of being really real about your life. And then, we can bring in the HRT and see how we can optimize.
When you say supplement versus takeover with estrogen, are you talking like supplement with an estradiol cream, for certain symptoms? Are you talking more supplements and herbs and things like that? Or
No, I'm talking about, creams and patches.
Versus full takeover being like injections, troches.
Or higher dose. Yeah. I mean, you're never going to get a high enough dose patch for full takeover. You're just not. You're going to need a supplement with a cream. So and I know women who are on patches and creams, and women, I mean, then we're talking about physiological rhythmic dosing, where you're following the cycle, and so that would be what I call the full takeover.
Yeah. So do you believe in cycling progesterone and estrogen post-menopause?
I do. And I believe that if we really want to optimize, it's an inconvenient truth, right? Because a lot of what we've been sold is like, no more period.
Yeah.
Done, son. Like, we're done. But in order for us to get hormones back to, physiological range where we are preventing disease, not just managing and mitigating symptoms, then you're cycling estradiol and progesterone, particularly cycling progesterone, which is going to bring on we call it a HRT bleed, but it's going to initiate a bleed every single month.
Yeah. I've been diving into this a little bit more because so many people are just on progesterone. They're on 250
all day, 24/7. Yeah.
And the cycling of hormones is what is also very cancer protective, and how they kind of yin and yang through why cancer obviously is such a lower rate pre-menopause. and how it skyrockets, even though hormones technically aren't higher, right? We don't have, in a lot of cases, they're lower. And so the hard thing is people that come off of progesterone high doses and migraines and sleep issues and having to like detox or essentially desensitize because the cells are just so used to this super loud scream all day, every day. But I love that you talk about that because I think it's something that is a little bit more recent, at least from what I've seen, coming out more hormone experts like yourself that are talking about the need for cycling and how
And rhythmic dosing. So cycling would be specific progesterone where you're cycling it 12 days on and off or 13 days on and off, depending on where you're at. Whereas rhythmic dosing is you're following the rhythm of your cycle for estradiol and progesterone. Now, estradiol you would be taking every day because that's how the cycle works, but you would be following that rhythmic cycle and you would be eliciting that estradiol peak right before quote unquote what would be ovulation so that you get the tumor suppressor gene activation, you get all those benefits. And again, I think women deserve to be educated, deserve to be informed, and then they can decide what they want to do, or they can experiment for themselves what's going to work for them. I know a lot of women who start rhythmically dosing and cyclically dosing and then decide it's not for them, or maybe they start with what I call, oh my gosh, I'm having a little moment, but static dosing. It's static, where it's the same thing every single day, all the time. There's no, eliciting that rhythmic response. So you just, again, probably the easiest way to do things is just like, okay, I take my 200 milligrams of progesterone every single night. I put my patch on twice a week and that's it. That's what I do. And that's what you're going to get from the standard HRT provider and practitioner, particularly your OBGYN, especially the loudest voices right now out in the space. This is how they're prescribing progesterone every day, estradiol patch twice. You switch it out twice a week, give or take. That's kind of what it looks like. That's static dosing. And some women will start it and be like, this isn't doing it for me. I don't feel great. And mind you, again, we still need to look at the lifestyle. We still need to be looking at your gut health and your metabolic health and all of that. But a woman can be like, wow, this isn't working for me. I'm not getting the results I want. Let me try physiological and cyclic dosing and see what happens when I do that. And so just know that you have permission by me to try all of it and any of it and see what works best for you and go from there. But also to be open to having the conversation of hormone replacement therapy as early as your early 40s, maybe even sooner, especially progesterone. I see so many women on progesterone even in their 30s, and it's a game changer.
Yeah, we have several clients that we've recommended it to just because it's bottomed out and it helps so much. But I want to have a reiteration of what you said earlier and then a question. So as you are listening to this, some of you might be thinking like, I'm on progesterone and I'm getting my labs checked and all is well and good. And depending upon your provider, I would ask, are they actually looking at more than just your hormones? Are they checking your cardiovascular health? Are they looking at your lipids to watch all the other things that, you've been talking about here? Because in my experience, for clients that have come in on HRT, I've asked them for blood work and lab work, and I'm not seeing anything besides
Just hormones.
the hormone panel, right?
Yeah.
So I think that we need to reiterate the importance of watching all those other markers when on HRT. And then also, I would love to ask you to talk a little bit about people who have had partial or full hysterectomies. How do they navigate this? Obviously, going a full hysterectomy throws you into the menopause, and that we should probably get those hormones on board as soon as we can. But for those with a partial who are no longer bleeding, are we just solely then going off of symptoms, kind of as you said before, and then kind of looking at lab work to see, when we could implement? Because I know a lot of people don't even think, they think like, I'm good. It's just a partial. Like,
yeah, there's a lot of misinformation about partial hysterectomies.
Yeah.
Yes, if you have a full hysterectomy before natural menopause, it's an immediate menopause. It's call it surgical menopause, right? And there's a lot of ways that we can go into surgical menopause. It could have been a surgery with endometriosis or a bladder surgery that just could have, accidentally had an impact on your reproductive organs as well. So just know it could be cancer, a surgical, cancer procedure that could do that as well. So just know that surgical menopause isn't just hysterectomy. It could be a number of things that could happen, around the reproductive organs. So just to kind of clarify. So it's always important to be looking at those labs and especially if symptoms start to arise earlier than you would have imagined, right? And there's a lot of reasons why we go into earlier premature menopause, that being one of them. But it could be medications that you're on or chemotherapy therapy that you're on, or it could be primary ovarian insufficiency. So again, just listening to your body and going, unfortunately, especially women who are in their 30s and their 40s and these types of things start to happen, a lot of them are getting gaslit and not investigated as to what is going on. And I wish I could say that we were all literate and we knew what we were doing out there in the world, but doctors know the training that they have. And so just keep pushing. It takes 6 to 7 visits to a doctor to even get, not that perimenopause is a diagnosis by any means, but man, you don't deserve to suffer. But for it to be identified, it usually takes about 7 visits, which is the same amount of time as like Hashimoto's or low thyroid function too, right? So just a heads up there. Back to the partial hysterectomy. So we take out the uterus, but we leave the ovaries. We also take out the fallopian tubes. And so there's blood exchange that's happening between the ovaries and the uterus that we cannot pretend to ignore. And then for some women, it's very, ultimately it's individually, but what we know is that the ovaries are going to retire out sooner than they were originally planned. And so, yes, I would be looking at hormones before that hysterectomy, that partial hysterectomy. I would be looking at hormones in labs afterwards. And then I would really, as a woman who has a partial hysterectomy, really be paying attention to those symptoms. And so most likely women with a partial hysterectomy will go into perimenopause earlier. And it can be a bit more intense. What a lot of us don't know is after many, many years over time, I know this is every time I think about it or say it, I'm just like, wow, this really happens. But our ovaries shrivel. If you're not going to use it, you're going to lose it. So it's just what it is. And so this happens earlier for women with partial hysterectomies where ovaries are like, oh, I guess what am I even doing at this point? My function isn't really there. And so we start to see declining hormone rates happen significantly faster. They may not be within the first month or 3 months or even 6 months, but ultimately it's going to start happening. And the first sign is going to be symptoms. But yes, please, if you've had a partial hysterectomy, keep on your labs, keep a timeline of your labs, and just really demand that people look at it, or get a functional doctor who's willing to have a much more nuanced conversation about the changes of your body, because it's bound that they're going to decline out probably a couple of years prior to when you would have gone into natural menopause.
So good.
I know. I mean, we're not completely against, like, there are some situations where they're totally warranted,
Absolutely.
People have horrible endometriosis or adenomyosis or just uncontrollable bleeding, right?
Yeah.
I have a lot of people like check and see if temperature rises is still happening.
Yes, absolutely. Check ovulation, all of that. Yes, absolutely. The biggest piece of advice I can give to any woman is always track your cycle.
Mhm.
And I get that with a partial hysterectomy, there's no bleeding, right? You're not able to track your cycle, but track that temperature. And again, I know that feels like a lot, but at the very least, track your symptoms. And if something doesn't start to feel right, I feel like this is one of the key symptoms of perimenopause is a woman saying, I don't feel like myself anymore.
Mhm.
If you're not feeling like yourself anymore, you probably, with a partial or full hysterectomy, you probably hadn't been feeling like yourself, but just keep listening to your body. If something doesn't feel right, that's it. It's time to go and seek support. And most likely you're going to need hormones.
Yeah. So can you give just a brief overview as we kind of wrap up here, what you recommend for women entering that mid 30s, late 30s? Like, what should we start looking at? What are things you can start doing? What are the foundations that you always go to? Like you said, hormones don't take you on a walk. They don't get you sunlight. Like, where do you try and get your clients to put a lot of emphasis on? I know we haven't talked about sleep yet. And
That's where we're going.
I loved what you said in Dallas, so you can say it again here. But, ultimately outside of hormones, because we've obviously covered that. We know that's important. People need to go that route. It is necessary.
It is full body necessary. If you want good health span.
Yes, exactly. Required. What else is there to support and emphasize the HRT effect?
Absolutely. Well, I'm always thinking about metabolic health, mitochondrial health. And that means I'm looking at metabolic flexibility in terms of, like, let's take a look at your blood sugar. Let's take a look at inflammation. Let's take a look at insulin. And so we can look at that in real time. So I'm a big proponent of a continuous glucose monitor to get a good sense of how is your lifestyle impacting one of the biggest biomarkers of longevity, right? Which is how your mitochondria are making energy. Again, we don't have an ability to look at insulin in real time, very easily, but we can do that with blood glucose. So optimizing your blood sugar. If 93% of us are metabolically unhealthy, you have to ask yourself, am I a part of the 7%? Or do I land in the 93? And I will tell you that the majority of women in perimenopause, unfortunately, are in the 93%. And so that's going to be an important, like, again, biomarker to look at. And then a big thing I'm always talking about is building a life around movement. Move your body. It doesn't have to be crazy. I like the big movements. I like the heavy weights. I like the exercise snacks, but I like walking and moving. It's mind blowing to me that over 60% of us are getting less than 5,000 steps a day, way less than that, closer to, 3 to 5,000 steps a day. The fact that we're living this sedentary life, I just think about how it being our life force. I always remember growing up knowing that movement was life. And so I would say more movement throughout the day is far more important than the big workout. I feel like that's the myth I was sold. Is like you get the big workout done early in the morning and you are done. You can just sit your butt in a chair all day and do work. And that is just not true. And then the last thing I think, especially for us as women, at least for me in my brain, that I have noticed makes all the difference. I always say sleep is going to make or break you. And so I want you to treat your sleep like it's $1 million meeting. Netflix, Severance, your partner coming to you with whatever they think you need to solve. Like none of those things are $1 million meetings. And unless it's $1 million meeting that you are coming to me with, get out of my face. Like leave me alone. Let me do me. It is my nighttime routine. And so I always say that your morning routine starts in the evening because it's really hard to get up at 5 or 6 o'clock in the morning if you didn't go to bed until 11 or midnight. And so have a solid sleep routine that I'm talking, red lights or dim lights, keeping the house low, have your supplements like magnesium or whatever you take before bed, your progesterone, if you're cycling it, and, honor that cycle. Honor the bedtime routine and honor the wake up routine. I would say that that's probably one of the most pivotal things that we can do for our bodies and for our brains.
Yes, it is so true. Sleep is
Everything.
Everything. Yeah. My husband makes fun of me. He's like, if you don't get 7 hours or more of sleep, I don't function. Like I feel hungover. I feel, and in my 20s, I probably could have drank a gallon of gasoline and gotten 3 hours and been fine. And now
it's a whole different ball game. And I need between 8 and 9. So I'm in bed at 9 and because I'm up at 6. I haven't been able to push the 5 o'clock button yet, but I'm up at 6 every day and I'm consistent. I'm up at 6 within 10 minutes. I would say the research is clear that the time that you wake up every day, that is going to set your circadian rhythm and don't deviate more than 15 minutes. So if 6 a.m. is my normal wake up time, I know I can deviate about 10 minutes or so. And then I am up. It doesn't matter. I don't care how little sleep I got or what the deal is. I get up between 6 and 6:15.
Oh, that's such a good rule.
Can we just, on that topic,
Yeah.
for the women who are like, yeah, but I can't sleep. I've got insomnia.
Yes. Yeah, absolutely. Yeah. That's a good question. Yeah. I mean, so.
But I have a lot of clients that are like waking up in the middle of the night and just, really erratic patterns. So again, this would go, I think, with progesterone cycling, but I'll let you share.
Yeah, progesterone cycling. And one of my favorite things, for progesterone is especially if you're compounding it. Note that prometrium is suspended in peanut oil and made with red dye 40. And yeah, so just a heads up, your cheap permetrium that your doctor is going to recommend, not my favorite, but, and it's just heartbreaking because it's so inexpensive, so inexpensive. And if that's what you can afford and that's what you can do it. But compounded progesterone, you can actually get an extended release where it'll get you through the rest of the night if you're really struggling. Another supplement I love, to support, things like chamomile tea, again, really just optimizing that sleep routine. But another supplement that I love that, again, be mindful of is pharmagaba that can really support sleep, getting to sleep and staying asleep. And that's really what you're hoping that progesterone's making. Also, again, everyone is different. Everyone's sensitive to whatever, but a little bit of melatonin. So I would really experiment with some supplementation and lifestyle strategies, like sleep strategies and routines that can help you stay asleep. Again, if I'm a proponent of if sleep is going to make or break you, that is very much the deal with me at this point in my life. After my brain injury 2 summers ago, I just don't have bandwidth for anything. Luckily, sleep is not an issue for me. I can sleep. I I'm very, very disciplined about my routine. And as long as I can stick on my routine, like I'm good. But I know that that's not true for everyone. And so bringing on a little bit of supplementation to help keep you asleep through the night, whether it's pharmagaba, or melatonin, or progesterone, and women ask, okay, do I absolutely need to cycle it? And ideally, yes. But if you can't sleep and you're like, I can't function, I can't get through my day, I'm a horrible person to my family, then maybe it's continuous usage. Again, you just have to make that decision. For me, it's pain meds for migraines or migraines. So, what am I going to choose? I want to be a kind, loving person to my family and my son. I want to be able to function, to be present. And that means drugs for migraines. And that's just where I have to land until I figure something else out. And I haven't yet. And goodness knows it isn't for a lack of trying. That's where I'm at. And so if you're telling me, hey, I would love to cycle progesterone, but man, I can't sleep without it, then that's what we got to do right now until we figure something else out.
Yeah. And like you said before, it can be a yes and.
It's
right?
a yes and, yeah.
It might be for some people that you need a couple of those. Like it might not just be one, and you might need to, play around with what that looks like. I just always tell people that, are struggling, like try not to become super reliant on it. Maybe try to cycle some of those sleep supports, because a lot of people will say, just like they do with certain laxatives and stuff like that. So they worked and then they stopped. Well, yeah, because, you need to cycle some of these things. Yeah.
Yeah. So for sleep in particular, I'll cycle women continuous for like 2 or 3 months. And then, cause let me tell you, if you're in perimenopause and you're still cycling and you go on continuous progesterone, kiss your period goodbye, kiss your cycle goodbye. You might as well treat it as a hormone, it's birth control. That's what a mini pill is. What do you think? Actually, a mini pill is less than that, and so, I just a little bit, I had a brain injury in the summer of 23, and we were trying to reduce the inflammation. I did hyperbaric oxygen. I did everything. But I also continuously dosed 200 milligrams of progesterone every single night, along with a lot of other things. And, my period was gone. It was offline, but I knew that was going to be the consequence of getting my brain back. And it was worth it. I knew it was short term. And so then I started cycling it again. So just note that it's okay if you need to give your system a reset, a reboot to get your sleep back online. If it means continuously taking progesterone for 2 to 3 months, again, work with a practitioner, be under supervision. There's a lot of tricks to get your sleep back online that are worth trying and worth committing to for 2 to 3 months until we can get your system functioning where you're back to sleep reasonably at a reasonable time and you stay asleep throughout the whole night.
This has been so helpful. And I think a huge part of our population is this age range and in the throes of it and struggling with it. So thank you, first of all. But second of all, what do you have coming? We have a book coming out in the near future. And where can people find you, follow you, give us all the details? We'll put them in the show notes too. But please let us know.
Yeah.
More of you.
I have a book coming out this year. I am so excited. It's called The Perimenopause Revolution. It really is the first perimenopause book to hit the shelves. There are more coming out in 26, in case you were wondering. There's a lot of us wanting to really talk about this. And it really centers around whole body hormone health and metabolic health. And so it's really putting the pieces together for you. There's a huge section on HRT and how to navigate that. And so I'm really excited. It's coming out in October of 2025. So October 21st. And so right now it's not officially up. It's coming up pretty soon to go and pre-order it, but I'm just so excited. You can follow me on Instagram at Dr. Mariza, so DrMariza. And I mentioned the girls, I have a Thriving in Perimenopause survival guide, because it's a yes and, right? We need a thriving in perimenopause, but also we need the survival hacks and to get through it. So it's a yes and this is, it's got functional lab ranges. It's got how to take labs. It has got what labs to ask of your doctor, a symptom tracker, menstrual cycle tracker. It's got everything you need to really get into the daily addressing of symptoms and the changes of your body during this profound transition.
Love it. Thank you so much for joining us and sharing your knowledge. And you are just a wealth of information. So we might need to do a part 2 close to when the book comes out to get you back on. But thank you so much for joining us. And we will be in touch, I'm sure.
Thank you.